Stand up right now. Just stand up from wherever you're sitting and try to straighten all the way. Feel that? That resistance. The pull, the ache, the moment your body hits a wall and refuses to go further. Most people felt something in the last 5 seconds. A twinge, a tightness, a deep grinding pressure that reminded you it's still there. And if you've been living with that, you've probably done what every reasonable person does. You've rested, you've taken something for the pain, and you've waited for it to pass. But here's the problem. Not all back pain is the same thing. Calling it back pain is like calling chest pain. It tells you almost nothing about what's actually broken. And when you treat the wrong type, you don't just fail to heal. You accelerate the exact damage you're trying to stop. There are 3 completely distinct mechanisms that produce what we call back pain. The first lives deep, a dull hydraulic pressure that builds after sitting and never quite releases. The second spreads, a burning, wrapping tightness that feels like someone cinched a belt around your spine and left it there. The third travels. It shoots, it fires down a leg or goes numb in a foot, and it appears in places that seem to have nothing to do with your back at all. These are not variations of the same problem. They are 3 different biological systems failing in 3 different ways. And the painkiller that temporarily quiets one of them is, in some cases, actively making another one worse. Start with the deep one, the one that lives in your lower back like a stone. The ache that wakes up the moment you've been sitting in a car for an hour or hunched over a desk all afternoon. The one that makes standing up from a chair feel like your spine needs 30 seconds to negotiate. That's not a muscle problem. That is a disc problem, and the disc is a hydraulic system. Each disc between your vertebrae is a shock absorber, a fibrous outer shell surrounding a fluid-filled core. That fluid is what gives the disc its height, its cushion, its ability to distribute load. But discs have no blood supply. They stay hydrated through movement, through compression and release, the mechanical pumping of walking and loading and decompressing. When you sit for hours, you stop pumping. The disc loses fluid. It flattens. And when a flattened disc gets loaded, when you stand up too fast, when you bend without bracing, the outer shell takes stress it was never designed to absorb, and the compressed nerve root sitting millimeters away starts sending exactly the signal you've been calling pain. A 2009 study published in the European Spine Journal found that sustained static loading of lumbar discs for as little as 2 hours produced measurable height loss and increased intradiscal pressure in the segments most prone to injury. 2 hours, that's a commute. And bed rest, the thing every instinct tells you to do, stops the pump completely. Rest for disc pain is not recovery. It's dehydration continuing in a horizontal position. The burning band is different. You know this one because it doesn't stay in one place. It wraps. It moves across the mid or lower back, sometimes pulling toward the hips, sometimes climbing toward the shoulder blades. It feels muscular, tight, like something needs to be stretched. And this is where the dangerous assumption lives, because what you're feeling isn't a muscle, it's fascia. Fascia is the connective tissue surrounding every muscle, every organ, every structure in your body. In a healthy state, it is fluid, gliding, a wet web that allows your tissues to slide freely. But fascia is 70% water, and it responds to chronic compression, shallow breathing, and dehydration by losing that fluid, matting, and adhering, turning from a gliding surface into something closer to shrink wrap. And here is why aggressive stretching makes it worse. When you pull on adhered fascia, you don't release the adhesion. You create micro-tears at the adhesion site, which triggers inflammation, which lays down more adhesive tissue over the injury. You stretch harder, it gets tighter. A study published in the Journal of Bodywork and Movement Therapies in 2012 demonstrated that sustained low-load myofascial release, not aggressive stretching but slow pressure below the tissue's resistance threshold, was significantly more effective at reducing fascial density and pain scores than standard stretching protocols. The solution is genuine systemic hydration combined with diaphragmatic breathing, which functions as a fascial pump, creating rhythmic pressure changes that physically move fluid through connective tissue. Slow, not aggressive, the fascia releases when it's coaxed, not when it's forced. Then there's the third type, and this one is the one that genuinely frightens people because it travels to places that make no sense. A shooting pain down the back of the leg, a numbness in the calf, or in 2 toes, a burning sensation that appears in the foot while the back itself feels almost fine. This is nerve compression, and the metaphor that makes it instantly clear is a garden hose. A nerve is a conduit. It carries signals, and when something presses on that conduit, the signal degrades before it reaches its destination. You don't feel it at the source. You feel it at the end of the line. The most common cause is compression of the sciatic nerve, either from a herniated disc pressing directly on the nerve root or from a contracted psoas muscle pulling the lumbar vertebrae together and narrowing the exit canal the nerve travels through. And here is the thing about treating this type with painkillers. A painkiller silences the alarm. It does not move the structure that is pressing on the nerve. And while the alarm is silenced, the compression continues. Nerve tissue, unlike muscle tissue, recovers slowly. A 2015 study in the journal Spine found that patients with lumbar radiculopathy who delayed decompression treatment by more than 12 weeks showed significantly worse nerve conduction recovery at 1 year compared to those treated early. Not because the pain was worse, but because the structural compression had continued without intervention while the pain signal was being chemically suppressed. The solution for nerve compression is decompression, specific positional movements that create traction along the lumbar spine and release of the psoas, which is often the hidden driver that nobody addresses. Sleeping with a pillow between the knees in a side-lying position creates passive overnight traction on the compressed segment. It takes days, not minutes, but it moves the structure. That is the only thing that matters. Now, most people living with this for months or years are not purely one type. You're probably a combination. A dehydrated disc that has compressed the nerve root, surrounded by adhered fascia that formed in response to the chronic inflammation. And this is why the revolving cycle never ends. You treat the nerve pain with rest, which worsens the disc. You stretch the fascia aggressively, which inflames it further. You take painkillers for the nerve compression, which silences the alarm while the compression deepens. Partial treatment of one mechanism leaves the other two running underneath. So the framework is this. Identify your dominant sensation. Deep pressure that worsens with sitting. Start with disc rehydration through movement, burning, spreading tightness. Start with hydration, breathing, and slow fascial release. Shooting, traveling pain. Start with decompression and psoas release. Then layer the others in. They reinforce each other once you're working with the right mechanisms. The spine is not a problem to be numbed. It is a system to be understood. And every treatment that has only half worked in your life has half worked because it was addressing half of the problem, or sometimes none of it. You now have the map. Start with what you feel most, follow the mechanism, and give the system what it actually needs, not what temporarily makes the alarm go quiet.